Welcome everyone, this is Dr. Sharad Jaitly, cardiologist from New York, on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the human heart and its illnesses. Without any further ado, I'd like to delve into the subject matter, and the matter of the subject today is bradycardia and bradyarrhythmias. What is bradycardia and what are the slow arrhythmias that we normally see called bradyarrhythmias? Well, bradycardia implies the heart rate being less than 60 by definition. Now, normally we have, say, a P, a QRS, and a T wave like that. Okay, so this is B, this is your QRS complex, obviously. Q is not being seen here, but then there's a T wave here. And this being the PR interval. So normally the PR interval should be less than 200 milliseconds. Anything beyond 200 milliseconds will define it as first degree AV block. So let's understand what first degree AV block is first. A first degree AV block implies that the PR interval is prolonged, and then you have a QRS and then a T wave. So this being more than 200 milliseconds will define the first degree AV block. Now, many times this is not symptomatic. There are times when it's symptomatic. If it's symptomatic, one really needs to know if it's related to any meds, like the beta blockers or calcium blockers. Obviously check that. This could be just reportable on telemetry or Holter or a simple 12-lead EKG on an incidental finding while the patient is coming in for a follow-up in the clinics. So, and that's why the importance of doing EKGs on a routine basis, specifically so if somebody's on a beta blockers, if somebody's on calcium blockers. So this way you can ascertain if there's any prolongation of the PR interval, prolongation of the QT interval, which we'll talk about at a later time. But the scope here right now within the video is mainly to define what bradycardia is and how can they be treated. Now, there are reversible causes, so these are the medications where you can take these patients off these meds and see actually the PR will return back to normal like this. And if it returns back to normal, then one can say that, look, you have been able to achieve what you may call the adequate control. Now, second degree AV blocks, there are of two types, remember that. And one of them is called Mobitz 1, again named after the physician. And the other was, obviously, if this is Mobitz 1, so this must be Mobitz 2, right? Okay, Mobitz 1 is also called Wenke-Back. So there was a competition here by another doctor in those years, and this is Wenke-Back. Okay. And the Wenke-Back implies that you have basically a PR interval which is prolonging over a period of time. And of course, you have a conduction delay to follow with. And then you have a P wave and then a prolonged QRS this time, and then a T wave here again. And then you have a P wave which is not conducted. Okay, so there's no conduction here, and this being the block. So what have you seen? You've seen a PR interval existing from here, and then which is prolonging now here. So the PR has prolonged, and this is classical 3 to 2 cycle. Why? Because it's 3 P waves, 1, 2, and a 3. And how many R's? 1 and a 2. So you have a 3 to 2 cycle here. So normally it is 3 to 2, 4 to 3, depending upon 7 to 6. So these patients can be symptomatic, may not be symptomatic, but very rarely they'll require any pacing. So very rarely I'll say pacing will be required, but otherwise normally they can be managed just by reversal of the medications, or even if it's related to say some degree of AV block, which is from degeneration or fibrosis, Wenke-Back is not life-threatening. So just remember that, unless and until it is symptomatic, and then of course then pacing evaluations can be done, and further Holters may have to be required, etc. So just remember that. The other type which we talked about is Mobitz 2. So let's do the Mobitz 2. Now, Mobitz 2, where you have a PR prolonged, and then you have a QRS, and then of course that's followed by a T wave here, obviously, and then a PR prolonged, and then you have a QRS just like this, and a T wave. And when you have a T wave here, but then followed later by a P, and which is not conducted, and then you follow later by another P. So you have a P, no conduction, no conduction. Whereas here you have a prolonged PR and a prolonged PR, but it's fixed. So the PR is fixed, and then you have P's which are not conducted. Here the PR is prolonging, it's increasing. So the differences are very, very clear. In Mobitz 1, which is Wenke-Back, the PR is prolonging, rarely symptomatic, and then there is a drop beat. Whereas here in Mobitz 2, this is 2 and this is 1. Mobitz, let's write that down here. So Mobitz 2, here you have the PR which is fixed. That's a very important finding. And then you have a drop beat. So suddenly a drop beat and the PR is fixed. So this is very, very symptomatic normally. Okay, that's how it presents with dizziness, syncope, and lightheadedness, etc. All these symptoms will be present, sometimes chest pain, palpitations, etc. Or skip beats, for instance, or fatigue. Now, it's normally seen in elderly. It's also seen in patients who are on certain medications like beta blockers and calcium blockers, like we discussed. But it also is present in Lyme disease and hypothyroidism. So these are some of the things which are treatable. Obviously, if you want to treat that with antibiotics and see that all this goes away, you can put a temporary spacing initially to try to circumvent the problem while you're treating the Lyme disease, the hypothyroidism, or there is an electrolyte abnormality. So that needs to be treated, etc. So you can correct the electrolytes, and sometimes it's also because of ischemia or infarction as well. We have seen it in acute infarcts also, specifically when the high-grade AV blocks can be a problem in certain infarcts as well. So very important, Mobitz 2 needs to be treated because this has symptoms. Mobitz 1 normally no symptoms, and it's very, very benign in terms of clinical presentations. And lastly, and not the least, is the escape rhythm. And I like to define the escape rhythms. There are two types of escape rhythms, if you will. And one is a ventricular escape, and the other is a junctional escape. Now, junctional escapes classically occur. Now, let's go to our favorite schematic, which is, of course, coming up, as you know, guys. Here it is. And this is your right atrium, and this is your left side. So the SA node being here, if you will, and the AV node being here, and then you have the bundle traversing like this, and then obviously the conduction goes up like that. Okay, so the conduction is traveling from SA node to AV node in this direction like this, and down here, and then all the way up, all the way up, all the way up. So the ventricular escape occurs when you have a rate which is originating from the ventricle, and normally it is only 30 to 40. So the rate for ventricular escape is 30 to 40. And for junctional escape, which is AV junctional escape, that means now you have a high-grade block, and now the junction picks up as becomes the captain pacemaker. Here the rate could be 40 to 60. So junctional escapes and ventricular escapes, if they are symptomatic, they will require a pacemaker. And otherwise, you may not require a pacemaker in these settings. Okay. Thank you again for watching MuniMeterHealth.com, your favorite website on our social channels and our social media. Once again, the goal is to try to improve the clinical outcomes and primarily to improve the medical education as well as the patient education, and that's where we stand for. So please continue to spread the word. Like the button if you enjoyed watching it and liked it. We welcome your suggestions and comments all the time, and your questions too, because they are very valued, and anything else particularly you want me to discuss, but I'm trying to cover everything within the scope of cardiology and the human heart here for you on MuniMeterHealth.com. Thank you again, and have a good one.